Muy buenas tardes a todos. Damos comienzo a la segunda parte de nuestro congreso. Muchísimas gracias a todos los que habéis mostrado vuestro interés en estas reflexiones sobre el buen trato a las personas mayores en las instituciones. Solo recordaros un par de cuestiones técnicas que ayer ya decíamos, pero que hoy me permito recordar. Primera, las preguntas que tengáis, hacerlas por favor a través del chat y no esperéis a que el profesor Zarit o el resto de ponentes terminen su ponencia, las cosas que nos tengan que decir, sino si las vais escribiendo mientras ellos están interviniendo, pues genial, ¿sabes? Para que así nos lleguen con más facilidad, porque serán los moderadores quienes elijan entre las preguntas que vosotros hagáis las que resulten de mayor interés. Segunda cuestión práctica. Todas las conferencias, tanto las de ayer como las de hoy, quedarán grabadas y una vez que finalice el congreso se subirán al canal de YouTube que tiene el Instituto de la Familia de la Universidad CEU San Pablo para que las podáis ver. Y también desde nuestro grupo de investigación vamos a publicar un libro con las reflexiones ampliadas de estas conferencias. Así que sin más, paso a presentar al primero de nuestros ponentes. Stephen Zarit is a distinguished Professor Emeritus of Human Development and Family Studies at the Pennsylvania State University, Penn State. It's a great pleasure for me to introduce him. He was my mentor almost 20 years ago. I was there in Penn State, and I learned a lot from him. El doctor Stephen Zarit es catedrático emérito de Desarrollo Humano y Estudios de la Familia en la Universidad de Penn State. Él fue mi mentor cuando estuve allí en la universidad hace casi 20 años y es un gran placer para mí introducirle y que esté hoy con todos nosotros. Professor Zarit, Steve, please tell us.
Well, thank you very much for that nice introduction. I'm really glad to be part of this conference. Good care is for older people and for people with dementia, it's a bold idea. It shouldn't be, but it's audacious. It's a way of getting at what really is one of the key issues as we move forward in our field. Care of persons with dementia in residential care facilities, which is my topic, is really what I believe to be one of the greatest challenges that we face in gerontology and geriatrics. It's a challenge to our creativity, to our resourcefulness, to develop better ways of caring for people with dementia. But I also think, first and foremost, good care for people with dementia in nursing homes is an ethical issue. For people living in residential facilities, these are the last days of their lives, and they deserve to live out their lives with dignity and with comfort and with respect from the people who are caring for them. There are many excellent care facilities, and I'm going to talk about some examples, but there are far too many programs that are at best mediocre, but in many times, and I know you have seen these kind of facilities, the care is dismal and demeaning. We can do better than that. As Thomas Kitwood observed, we lose sight of the person with dementia and create environments that are dehumanizing and degrading, even while espousing noble platitudes and good intentions. My goal for today is to get my PowerPoint working? There we go. Okay. My goal is to present a framework for viewing goals and challenges to doing good care. And I think, there we go. That's what I want to be. Framework for good dementia care. And then I'm going to talk about some best practices approaches toward the end of my presentation. In doing so, I'm going to present some examples from the United States and some European innovations, particularly Sweden and the Netherlands. I don't know a lot about long-term care, care for dementia persons in Spain, and so I apologize if I say things that you already know or that really don't apply to your situation. The basic component of a high-quality program of good care is something you're all familiar with, which is person-centered care. When we talk, and person-centered care involves a couple of things. It involves respecting the individuality of persons with dementia, and it involves knowing the person's preferences. If we're going to do person-centered care, we need to know what the person wants. Now, that can be a challenge. It's a challenge because persons with dementia sometimes have difficulty expressing what it is they want. So there are ways of getting at what the person wants, what the person's preferences are. One way, and this is probably what typically happens, certainly in the United States, is an older person with dementia moves into a care facility, a nursing home, and a staff member may get a brief biographical sketch from the family, or maybe from the person with dementia themselves. And they feel that's sufficient, but it isn't. Getting to know someone and getting to know their personal preferences needs to be something that continues over time. Now, one of the questions really is, well, can people with dementia really tell you what they want? The answer to that is they usually can in early and middle stages of the disease. And often they can continue to show you and tell you their preferences even in the later stages of their illness. Now, there are some tools that can help understanding a person's preference. And I want to mention one, a tool that's called the PELI. The PELI stands for Preferences for Everyday Living. It's a measure developed by Kimberly van Heidsma and her colleagues. It's a questionnaire and checklist of a number of items, and it yields 5 categories of preferences for everyday living. Preferences for how much autonomy the person wants in their self-care, preferences about getting other people to help in their care, preferences for leisure and other enjoyable activities, preferences around social contacts, and then something that Van Heidsma and her colleagues call growth activities, which I think is a really nice concept. Something like keeping up with the news or other kinds of stimulating growth activities that we may overlook with persons with dementia. Now, one of the things about the PELI is, and about identifying preferences, is preferences can change over time. The reference you see on the right-hand side of this screen, a paper by Abbott and colleagues, looks at change over time, and they find that residents with dementia do change their preferences, but they're doing it in a more active way. It's not random. Today I feel like this, yesterday I felt like that, but their engagement in answering questions on the PELI is very they approach it with knowledge, with an understanding, and they're able to say their preferences, and they're able to tell you in a reliable way what they want today. There's a very nice study that was done using the Pele and showing its usefulness in long-term care. This was a study published, that was Van Heitzman et al. Published in 2015. It was a randomized trial. The participants were early to advanced dementia, so some people with more serious degree of cognitive impairment. People were randomly assigned to 3 groups. The experimental group had a staff member work one-to-one on daily activities with persons with dementia using the Pele. So the activities were individualized to that individual. It was the things they wanted to do. The second group was an activity control group. This was standard activities, the kind of things the institution typically did with residents, but they were also delivered one-to-one. So this is controlling for the amount of individualized attention. And the third condition was a usual care control group. Findings, I think, are very interesting and very powerful. The individualized group had the people receiving individualized activities from the Pele had more positive affect and more positive verbal and nonverbal behavior. And the individualized group also had less negative affect than the other 2 groups. So it shows that the Pele is an effective way of understanding and using the preferences that persons with dementia tell us about. I also want to note that the research was very clever in its choice of good outcome measures, observational measures, and verbal responses, things that we can get reliably from persons with dementia. So overall, it was a very good study. When, obviously there are times when people can't tell their preferences, and then sometimes we have to go on a trial and error basis. One of the things that I found very effective, I learned from a program called One Generation. One Generation is it's not a nursing home, but it's an adult day program, adult daycare program that's in the same building as a child daycare program. And One Generation mixes those groups together in a very planful way. So they've designed intergenerational programs, and twice a day, the children march over to to their friends, as they're called, in the senior program, and they interact. The thing I want to mention, it's really a terrific program. What I want to mention is the staff take each activity, and afterwards they write down how it went, and they write down what they need to modify next time. And this is really a key because they're continually improving the activities that they're delivering. And that's something that could be a very important part of person-centered care. You might get it partly right the first time you try an activity, and then you can improve it partly with the feedback you get from the person with dementia, and partly just carefully observing what the reactions of the person with dementia were. Now, person-centered care is something we all know about. It's something we all talk about. I imagine none of you have gone into a nursing home recently where they didn't tell you, we do person-centered care or something like it. And so it's such a basic concept and everybody says they do it, but why don't more people do it right? And the reason for that is that I believe there is an inherent tension between institutional needs and persons' preferences. Let me explain what I mean. I have a couple of points on this, but I want to start with what the authors in this paper that I'm showing you talk about. The paper is by Tove Persson Harnett and David Westerfors, two Swedish academics. This was actually part of Tove's dissertation. And it really goes to the heart of why a lot of institutions that care for the elderly aren't doing better. This is, I want to say, I think the most important paper I've read on long-term care in the last 20 years, and I would encourage you to read it. Now, let me give you a little background to the paper. Autonomy of people with dementia is a key feature of person-centered care. It's a key to the quality of life. And in Sweden, where this study was done, there's even a law that says that autonomy of persons with dementia in nursing homes should be respected. What the article shows, however, is that staff finds reasons not to respect the autonomy of persons with dementia. These are the reasons we hear every time we go into many nursing homes. So, for example, a resident is on a schedule for a shower or a bath, and the staff comes up to them and the resident says, I don't want one today. And the staff insist. Why do they insist? Well, it's on their schedule. Schedules are very important. Or here's another one. Another example from the article. It's at around 8 o'clock. The staff want most residents to go to bed. Why do they want them to go to bed now, even though residents don't want to? They say, well, staff, the night staff who come in, it would be unfair to them if they had to put everybody to bed. So we want to get most people together to bed now, and then it'll be easier for our staff. So the institution's requirements are more important than the personal preferences of residents. Another thing that happens, and this is the title of the article, is the staff view the requests of residents as trivial, as unimportant. So if the resident complains that the food at dinner was cold when it got to them, the staff say, oh, they complain about everything. They're so spoiled. They don't take it seriously. They say the complaints are trivial. It doesn't matter if people get their preferences. In some, it's more important to the staff, even in what are generally considered very good nursing homes. It's more important for the staff to maintain routines. They say it's not fair to the staff to individualize care and so on. And by not respecting these preferences, this undermines the independence and autonomy and the self-esteem of residents. This is a terrific article, and it gets at the heart, I believe, of why nursing homes fall short of delivering true person-centered care. And I'm going to come back to that with some examples where people get past this emphasis on we have to do what's good for the institution, for the staff. I'll come back to that. One other consideration that I want to mention is the autonomy security dialectic. This is another reason why it's hard to do person-centered care. The autonomy security dialectic was originally proposed by the late M. Powell Lawton, who was one of the pioneers in the study of the environment and its effect on persons with dementia, and his colleague Patricia Parmalee. What the autonomy security dialectic is saying is that for people who need care, they need autonomy, but they need security. They can't get into a situation where they're likely to get injured. So any institution is faced with balancing between keeping people safe and allowing personal choice. What Lawton argues is that it's easy to upset that balance. You have to have some safety, you have to have personal choice, but for institutions, there's an inherent, built-in bias towards safety. Why is that? Well, you all understand that. Resident falls. That's a terrible thing, especially if there's an injury. The nursing home will be upset, the family will be upset, the whatever government officials oversee the facility will be upset. So there's a built-in bias toward safety. But the problem becomes it takes away, too much emphasis on safety will take away individual initiative. And Lawton said that the lack of challenges, the lack of the ability to be able to express yourself in a setting leads to boredom, demoralization, and functional decline. In sum, what I want you to take home from these two perspectives, the trivial matters paper and the autonomy security dialect, is that we need to understand the institutional processes that undermine autonomy and personhood. We often don't see them, or we often blame the persons with dementia for being so difficult to care for, and that's why we have to do such and such. There are ways of setting up more healthful processes to provide care. Okay. Well, let me see what's happening. My PowerPoint seems to be stuck. Okay, there we go. I want to talk next about best practices approaches. Start with the therapeutic environment. The therapeutic environment is something that was developed in mental health care in the 1960s. And the idea was, let's design the environment in a way that supports positive engagement and supports a high level of functioning. With dementia care, a lot of the emphasis in designing environments has been around how do we minimize the cognitive problems that people have, and how do we create a setting that gives them a higher quality of life. There are two components that I want to talk about in terms of the therapeutic environment. One is the built environment, the architecture of the environment, and the other is organizational policies and procedures that deliver good care. Now, the research on these things show positive effects, and I'm going to talk a little bit about the research, but pretty much every feature of the environment that I'm going to talk about has been studied to some extent and has generally shown positive effects for the persons with dementia, in some cases positive effects for families, and in some cases, and this is important, positive effects for the staff. So what are some features of a therapeutic environment? And I think here you probably are familiar with many of them. Let me see if I can. Okay. One feature that I want to start with is the idea of special care memory units, places specifically for persons with ADRD. A lot of the environments I'm going to describe were programs specifically designed for them. And we'll talk a little bit toward the end about pros and cons of special care units. One of the features of a therapeutic environment that's very common is a home-like setting. This photo that you see is one that from a Swedish group home, which were small, high-quality residential care facilities for persons with dementia in Sweden. Unfortunately, the group home has been largely phased out, but it was a really wonderful idea, and you can see in the photo the home-like environment, a very comfortable-looking chair, plants on the window. The environment was actually, the furniture was actually purchased by staff for the common areas, with an emphasis on getting things that looked older, comfortable, things that the residents would be familiar with. Now, one of the key features of a therapeutic environment, this is really not designed, it's more of a policy procedure. Residents should have their own rooms. It is just a horrible thing to put a person suffering from dementia who's 80, 85 years old in a small room with a stranger who they may have nothing in common with. That is the most demeaning thing you can do to a sense of personhood. Residents should have their own rooms. I don't know your situation in Spain. I know in the United States that the double room or triple room is still probably the most common. And our government, to the extent that it pays for long-term care at all, mandates that when it's paying for care in a nursing home, the resident receiving financial assistance can't be in a single room. That's just horrible from my point of view. Now, another thing related to that is allowing residents to have privacy, having them the opportunity to close their doors. In the Swedish group homes, they not only could close their doors, but they could lock them. And that's really an interesting idea. It's really giving people autonomy. One reason they could do this is they sign a lease to an apartment in these group homes. So, and that set up an expectation with staff that the residents, that this was the resident space. Their apartments belonged to them, and they could do what they wanted consistent with safety. So they could lock the door. Now, staff had keys. I don't think, and they could get in if they needed to, but I don't know that I've seen that anywhere else, but it was an interesting idea. One thing that's very common is personal furnishings, bringing things from home and furnishing their own rooms the way they wanted. Another thing is lots of natural light. You see the big windows in that photo, and also a soft light, not bright overhead, stark neon lights, but softer lights, and good acoustics. By the time we're all old, and I'm speaking for myself now, our hearing isn't as good as it used to be. Too much rock and roll. And acoustics need to be good. both for communication, but also there needs to be very little background noise. My wife and I visited a nursing home once where they had a big ice machine in the dining area, and it just drowned out any opportunity for conversation. Just crazy things that people do, not taking into account things like light and acoustics. Other features of a therapeutic environment. Outdoor areas can be very important, very useful. Sometimes they're talked about as wandering gardens. People can go out and walk around in the outdoors on their own. One of the things that allows that is creating a secured environment for the person. If a facility only has an interior unit, they can have a locked door so that people can wander freely within the unit. If they have an outdoor area, there can be doors that the residents can go in and out of and go out into a secured area outside. And these are very important things. Staff don't have to try to restrict people who otherwise might go out of the unit on their own, get lost or get into difficulties. But at the same time, it can give them a safe area in which they can manage. There are people who say locked units are wrong. It's a violation of personhood. When I began working in this field, nursing homes and dementia units, nursing homes were open. They had no way of controlling people with dementia. They eventually would resort to restricting people to a bed or to a room. Having a lock has the paradoxical effect of allowing freedom within a relatively safe setting. One other feature I want to mention is wayfinding cues, helping people find their way around and find their way back to their own room. That's something that's used a lot. Sometimes well, sometimes it could be better. The photo, of course, that I have here is it's the plan of a dementia village in the Netherlands. I'm sure you've all heard of it, and it's really an interesting idea. I understand there's some controversy about it, but I think on the whole, it's a very interesting idea. Actually, here's another photo from it. One of the things we're trying to do with a therapeutic environment is normalizing life, making it seem like the things that are familiar and comfortable and interesting to a person. And I show this photo from a dementia village because where are they? That's a pub. That's such a wonderful statement about how we're going to give care to persons with dementia. We're going to let them have a drink. They're adults. For most of them, a glass of wine or a beer isn't going to cause any medical problems. Certainly you don't want people drinking too much, but it's a place where the autonomy, security, the dialectic can be seen very clearly. A lot of facilities would say, "Oh no, we can't allow it. They'll drink too much. They'll have a medical problem," and so on. If you're 85 and you're living in a care facility, wouldn't it be nice to have a glass of wine at dinner at night? Wouldn't it be nice to be able to go to a place in the residence and sit down with a couple of friends and have a beer? That's normalizing life in a dementia care facility. Some other features of a therapeutic environment, actually I'm kind of getting now into the care procedures that the staff introduces. One thing is managing behavior problems. We don't train people to competency in managing behavior problems. Facilities say, oh yes, we know how to manage behavior problems, but you find out what that is, and they don't have a clue. There needs to be consistent training up to a level of competence for knowing how to manage behavior problems. One source of a program is the wonderful work that Linda Terry at University of Washington has done over the years, where she's trained staff in nursing homes and in assisted living facilities, care facilities, on how to do a systematic approach to managing behavior problems. And it works. It does help programs manage problems in careful, respectful ways. And everybody's happy then. The person is happy, the family's happy, the staff are happy. Another issue is size of the unit, and the picture here is from the Abramson Center for Jewish Life outside of Philadelphia in the United States. And the facility was actually designed by Paul Lawton. One of the things he did is he broke this large facility into pods. So this is this is one area where 9 residents lived. And this is where they would come out in a common area. They could use those tables for activities, and those were the areas where they were served meals. Lawton felt that units needed to be relatively small size, and smaller units in the literature, again, tend to show positive effects. Another thing that can create a therapeutic environment, pets and plants. I talked about plants, but pets are something that's fairly common. And one thing that seems like it should be obvious, but it's often overlooked, is making families feel welcome. In the Abramson Center, Lawton included a game center for teenagers. So grandchildren and great-grandchildren would come, visit their grandparents, and they could go off for a while, play some games, come back. One of the things that was described to me that happens at the Abramson Center is that the grandkids come because they're attracted by the game room, and they'll help their grandparents with electronic devices, phone, iPad, or whatever they're using. So it can work both ways. There's a couple studies that I want to talk to you about that Carl Pillemer and his colleagues conducted. I don't know if Carl talked about this yesterday, but it's really an interesting study. What they did, they recognized that there's often conflict between staff and families, conflict in communication, conflict over what should be done for the person with dementia. And so Pillemer and his colleagues developed a program to train both families and staff, not just one, not just families, not just staff, but to train both in communication techniques and conflict resolution. What they found is really striking. They found that the training resulted in an increase in positive communications. The training led to staff reporting less conflict with family. The staff also reported that their own feelings of depression were lower. That's really remarkable. We often overlook the staff's feeling, or we blame the staff for what's going wrong. But giving them this training helped them feel better on the job. And this is just a remarkable finding. The last finding, that residents whose family participated in training had lower behavior problems after the training was completed. So something about how the families were approaching the person with dementia, how the staff were approaching them, led to lower behavior problems. Just really a very important finding. I want to mention a way of assessing the environment. There are a number of measures, but one that's widely used is the TESS, the Therapeutic Environment Screening Survey for nursing homes. It rates 15 different characteristics of the environment, and there are empirical findings that support most of those characteristics. Finally, I want to end by talking about a setting that combines architectural design, therapeutic design, and principles of good dementia care. The place is called Woodside Place. It's located in Oakmont, Pennsylvania, which is just north of Pittsburgh. It's been open for 25 years and has maintained over that time. This is actually remarkable. It's maintained a very high quality of program over that time. Usually a program gets started, there's a visionary leader, it starts off well, and then the leader leaves and things fall apart, or they go revert to the median of mediocre care. Woodside Place has managed to maintain a high quality of care. Now in the facility, and I don't know if you can see my marker, you can see the facility and how it's built. There are 3 wings, which is where the residents live, and that opens up to an area where there are big rooms for common activities, and there are dining rooms for each of the 3 wings, although people can eat in any of the dining rooms they want to. There are wayfinding markers throughout the facility. Each wing is decorated in different colors. Their doors, their residents' doors have a photo of them when they were younger, which they'll recognize, not how they are now, and other things that show it's their room. It's mostly private rooms. The only rooms that are double rooms are rooms designed for couples who go into the facility together. There are activities throughout the day, and there are lots of windows to let in light, and a garden area. I'll show you. You can see the garden area. You see this path in the garden. People can go out on their own into the garden. They can walk on their own, and there are activities for them in the garden. These are things that a lot of places use. Here is a place where it's part of a larger package of therapeutic design principles. Now, that is combined then with principles of dementia care. They talk about being person-centered, and the way that comes through is in the important way that they emphasize the person, not the routines. So a person says, they approach a person and say, would you like a shower? And the person says no. They'll come back another day. They won't say, you're on the schedule today. They'll say, okay. And they'll come back. And so they'll come the next day and they say, okay, we're not going to force anybody, and eventually they'll say yes, and they do. Staff are trained in behavioral management skills. I was, well, actually, let me give you another example of emphasizing the person, not the routines. This is rather remarkable, I think, because I've never heard of this before. So at night, they have 3 staff, 1 person in each of the 3 wings. And during the night, residents, if they get up, they can sit and talk with the staff person. They might get something to eat. They might have some activities, and then go back to bed. Well, a recent time when I visited, they had a larger number of people than usual getting up early in the morning before the morning staff came on duty. And it was beginning to overwhelm the night staff. So what a typical facility would do is say, okay, you have to go back to bed, give them sleeping pills, whatever. What Woodside Place did is say to contact one of their day staff and have that person come in an hour earlier, and that solved the problem. What they're doing is adjusting their routine to the person with the dementia, not expecting persons with dementia to adjust to their routines. Whether a person with dementia is at home or in a nursing home, they're not going to be able to adjust to someone else's routines. We need to adjust to their routines. We need to understand their routines and adjust to them. Other things, high quality behavior management skills. I was going on a tour with a colleague of mine recently, and everything was quiet. People were going their own business. They were walking, they were doing things. And so I decided I'd ask, what about behavioral management skills? And it was like listening to a lecture by an expert on behavioral management. They know how to do it. She said, well, we get to know people and we kind of know what works with them. And if that doesn't work, we look for antecedents and consequences, and we do trial and error, and we find something that works. And so they don't have to use medications. And they end up with positive effects. I think it's about time for questions and answers. So let me just say, as I said, many of these features of architectural and program design have been shown to have positive effects, and here are some reviews of the literature. I'm going to skip these things and just go to the discussion. And thank you very much for listening. So how do we do discussion? I guess I get out of, let me get out of this and turn the screen over back.
For your inspiring presentation. The first question is from Teresa Martinez. She was one of our speakers yesterday, and she asked us, please give us some recommendations on the size of small living units. So it's about the site, about how many residents in a small. She assumed that not many people in the living units.
Mm-hmm. Yeah, and I think the literature emphasizes that smaller units are better. And Dr. Lawton felt that 9 people was an optimal number, and it was based on a lot of studies of at what point were social interactions more likely to occur, and they felt 9. Now, other programs may have 15 or 20. The Swedish nursing homes actually tended to have between 7 and 10 in a unit, but they might put 2 units next to each other. And Lawton's facility actually was a very big facility, but they had units within it of people of 9. So you could have a larger facility, but have small units within it. Woodside Place, each of the 3 wings had space for 12 residents, and that seemed to work well. And it seemed to work well for them to have the whole of the unit be able to come out and interact in the larger area. There's probably no magic number, and an environment with a lot of space could handle somewhat more people. And if you have a small environment, you really need to keep the numbers down.
Mm-hmm. Thank you. Our second question: how we can individualize activities in regular nursing homes with high staff to resident ratios? It means, at least in Spain, we have a lot of residents and few staff. How we can individualize activities with such ratios?
Yeah, I mean, that's a challenge. That's really one of the major problems. But I think staff can still do an instrument like the Peli, so that they know at least what people like. They can find people with some similar interests and do small group activities. Then I've seen people in staff just pull people out of rooms and put them together. And if you have some background and information, you can find people who like certain activities and put them together. You can also have, I don't know if this would be common in Spain, it certainly is in the United States, to have volunteers who come in, and instead of the volunteer having to come up with an activity, the Peli could be used to help the volunteer do activities with a single person or with a few more people. But the challenge, I don't want to underemphasize it. The challenge is we do need more resources, and we do need help in building these environments.
Mm-hmm. A third question is about families. Why families are not very welcome by nursing homes staff?
Why they're not?
Why are not welcome by nursing home staff?
It can be a number of reasons. Some staff are abusive toward, some residents are abusive toward nursing home staff. There actually were studies about 15 years ago that showed some of the terrible things that happen between families and nursing home staff. And the families probably tell the staff what to do, and they have expectations for care that the staff can't make, things like that. And that's where I think the training that the staff and family training that Carl Pillemer did could be very helpful, and opening ways for staff and families to be able to talk to each other more effectively. It was actually my wife Judy worked as a clinical psychologist for many years, consulting in nursing homes, and it was one of the things she would talk to families about, reminding them to talk respectfully to the staff. And if you do that, of course, it benefits the family and it benefits the resident, because the staff then respond more positively. But it's a key issue and an important issue.
Thank you, and give our regards to Judy, please. And the fourth question, you talk about the interaction relating autonomy and security, but one person asks us about what's your opinion about privacy and identity versus security interaction?
Oh, I think it's part of the autonomy security dialectic. I think privacy is important. Being able to go into your room and be alone is important. Being able to close the door. I mean, if most of you have probably been a hospital patient at one time or another, and the doors are open, and that's understandable. It's only a few days, but there's light coming in and people going through all night and noise and you don't sleep well, and it's if we lived in a facility where it was like that all the time, it would impair sleep and demean our sense of personhood and so on. I think it's very important to allow for privacy. And privacy, what kind of trouble is the person going to get into? You can't you can't eliminate all risk, but if you do too much on the side of eliminating risk, it harms the person. So I really agree with what the question was about, that we have to balance privacy and security.
Thank you. And one final question. What's your opinion about coronavirus, COVID-19? How coronavirus can help us to improve our good care in nursing homes?
Oh, that's an excellent question. It can help in some fundamental ways. One, nursing homes have to be prepared for infections. In the United States, they get some training. They're supposed to have equipment on board. They're supposed to know what they should do in case of an infection. There's a flu season every fall. And while staff may get their vaccinations and residents may get their vaccinations, we know that people get sick in nursing homes from the flu and they die. It should be a normal part and an emphasized part of the things that the nursing home does, and that they have resources that are present. The other thing is, if people had single rooms in the United States, there would be far fewer deaths. Instead, what happened is someone would get COVID and they'd be left with their roommate. Or even worse, people from the outside who had been hospital, who had COVID, were moved into the nursing homes and put in rooms and on corridors in units with people who didn't have COVID. It was just crazy. I don't know what to say. I was going to talk about politics, but it was just, it made no sense from a health or public health point of view what was done, and we should learn from that. So I think those would be two places to start. I'm not an expert in infection management, but there are lots of smart people who could say every nursing home should be following these rules.
Well, our time is over. Thank you so much for your presentation, for your ideas. I really appreciate your contribution, Professor Zarit. Muchísimas gracias. Ustedes se dan cuenta que podríamos estar hablando muchísimo más tiempo con el profesor Zarit, que siempre tiene pues cuestiones pues que nos inducen, ¿no?, a ir más allá y a pensar más allá, pero es tiempo de pasar a la siguiente mesa redonda. Así que le damos las gracias y le agradecemos su participación en esta conferencia. Thanks, Steve.
Gracias. Adiós.